Welcome back to Revenue RX, the podcast at the intersection of pharmacy and finance. I'm your host, Lubna Mazen. Today, we're diving into the July 2026 HCPCS coding updates and what pharmacy revenue cycle teams need to know before these changes go live. Every quarter, CMS releases new HCPCS codes, revised descriptions, deleted codes, and reimbursement-related changes. These may look like simple coding updates on paper, but operationally, they create major downstream reimbursement implications. One missed HCPCS update can lead to denied claims, delayed reimbursement, underpayments, or revenue leakage that organizations may not identify for weeks or even months after the go-live. Today's episode breaks down drug and biosimilar HCPCS additions, revised and deleted codes, CMS's continued expansion of manufacturer-specific 505(b)(2) products, and new COVID-related M codes that highlight how administration reimbursement continues to evolve alongside medication reimbursement. This episode is based on the CMS July 2026 HCPCS coding decisions and MLN guidance. This episode was recorded before July 1st, so any updates that occur since recording will be posted in the description. Let's start with new HCPCS codes that will be effective July 1st of 2026. J0528, Contepo, phosphomycin disodium. J1289, Yartemlya, narsoplimumab. J1577, Kevigi, immunoglobulin. J2361, Extenture, depemokimumab. J2374, iopidine, ophthalmic solution. J2789, Epoxia, riboflavin, ophthalmic solution. J3386, Waskira, ituavitagene, autocell. J3405, Itvisma, onasemnogene arpavarvovec. J7176, Facility, human fibrinogen. J9062, Ribavant Faspro. CMS also added A9574 Varfarabrite, which is an imaging injection, and there are also two immunization vaccine CPT codes that were added, 90616 and 90639 for mRNA influenza vaccines currently pending FDA approval. Biosimilar HCPCS additions include Q5164 for Stargemza and ustekinumab biosimilar, Q5165 Ozeltis, a denosumab biosimilar, Q5166 Osveritine and Juberec, both denosumab biosimilars, Q5167 Inobi and Extrinbo, additional denosumab biosimilars. Q5168 Nufilmco, a ranibizumab biosimilar. Q5169 Armlupeg, a pegfilgrastim biosimilar. Q5170 Idenzilt, etribolizept biosimilar. Q5171 Bonkresa, a denosumab biosimilar. As the FDA continues to add new biosimilars to the market, we are continuing to see new operational complexity as well as reimbursement complexity. The biosimilar space is highly mandated by payer-specific mandates. What we hope to see is continued multiple product selection rather than one specific preferred product or one restricted product. For deleted and reinstated codes, CMS announced that effective July 1st, CMS has deleted code C9309, which is for Itvisma, which has transitioned to a newly established J3405 code. In terms of cell and gene therapies, these are multi-million-dollar therapies. Please ensure that single case agreements and prior authorizations are written for the new code. This kind of transition creates a significant risk for health systems. If health systems choose to build the automation for cell and gene therapies and they have a prior authorization or single case agreement for the deleted code, they will need to reverse all billing that occurs. CMS also reinstated J9037 for Blenrep, Balatunumab, Mafo.in. This is following FDA approval in relapsed or refractory multiple myeloma. This is yet another important reminder that reimbursement infrastructure must continuously adapt to regulatory and clinical changes. For 505(b)(2)s, CMS is continuing to revert some 505(b)(2) drugs that were previously assigned their own billing codes back to the reference product code. This is because they have been identified as being therapeutically equivalent in the Orange Book. New code J9232 for Hospira brand Ducet-Axel. This is specifically identified by CMS as not therapeutically equivalent to J9171. There was also a revised description for J3375 for Tizavan, which is vancomycin hydrochloride. One of the most interesting parts of this new update is the addition of M0231 and M0232. These are administrative codes associated with Q0234 for Tofidence, which is tocilizumab BAVI. CMS established Q0234 for the drug itself, M0231 for the first dose administration, and M0232 for the second dose administration in hospitalized adult COVID patients that require supplemental oxygen, mechanical ventilation, or ECMO support. This is where pharmacy revenue cycle becomes especially operationally complex. Now, you not only have to worry about the medication billing, you also have two different codes for the administration of the drug. The administration pathway of many drugs have their own coding requirements, documentation requirements, monitoring workflows, and reimbursement implications. Organizations must operationalize not only the drug billing, but also the administration charging, along with nursing and provider workflows. These new M codes are yet another reminder that reimbursement continues to evolve beyond traditional drug billing. Questions organizations should be asking themselves right now before the July updates go live include: have all the new HCPCS codes been built in the EHR? Have the deleted codes been retired from billing workflows? Have revised descriptors been reviewed? Have reimbursement rates been uploaded? Have billing units been validated? Has the NDC crosswalk been updated? Have payer policies been renewed? Have administration workflows been validated? Have claim edits been tested? Have denials prevention teams reviewed high-risk therapies? Reimbursement failure rarely happens because of one catastrophic mistake. Most revenue leakage happens through small operational disconnects across multiple systems and teams. Healing patients is the mission, protecting the margin is the strategy. This is Revenue RX. If you enjoyed this episode, share it with a pharmacy leader, reimbursement specialist, or revenue integrity professional preparing for the July HCPCS updates. Disclaimer: the contents discussed in this podcast are intended for informational and educational purposes only. They reflect my personal opinions and experiences and do not reflect that of my employer or associated organizations. This podcast does not constitute as legal, financial, or reimbursement advice. Please consult with the appropriate internal experts before making any decisions.